So what are the signs? Signs is lag of thalos. Lag of thalos again by definition is an incomplete closure of the eye. Incomplete closure of eye. So these patients will have lag of thalos. When we attempt to close the eye, there will be a small gap that is visible in these patients. You can see in this picture. This is classically what we call lag of thalos. When the patient is asked to close his eyes, you can see that there is normal closure on the right side, the normal eye, and there is inadequate closure. This is called lag of thalos. This patient probably has a lag of thalos of about 4 to 5 millimeters, and you can also see here the nasolabial fold is present on the normal side, but it is completely absent on the abnormal side. Now, the danger of lag of thalos is if there is exposure of the inferior aspect of the cornea, then it can result in what you call exposure keratopathy. As long as the cornea is not involved, the patient does not have dangers of developing punctate erosions, which can then progress to corneal ulcer. But if the patient's cornea is beginning to get exposed and affected, the patients can start developing severe conjunctival redness and edema, and we do a fluorescent staining with 2% fluorescent. That's what you're seeing in this picture. 2% fluorescent has been applied and patient is being seen under cobalt blue filter, and you can see these small dots here. This is classically exposure keratitis where the punctate erosions have taken up stain. If this is not treated adequately and early, this can progress to a corneal ulcer, and like I mentioned previously, there can be lid retraction due to unopposed action of the levator palpebrae superioris muscle. So why is it that these patients have dry eye and epiphora? Many of them have dry eye and epiphora that coexist, which is paradoxical. Dry eye is reduced amount of tear film and epiphora is increase or watering of the eyes. So why does it happen? Basically, the problem is because of there is often orbicularis oculi muscle weakness or paralysis. So epiphora or watering occurs because there is decreased muscle tone on one side of the face. So when there is decreased muscle tone, we have already seen that orbicularis oculi muscle is very important in tear drainage or the lacrimal pump mechanism. So when this tear drainage does not occur, there can be the epiphora it can lead to stagnation of tears in the eye. Whereas dry eye occurs because there is decreased apposition of the eyelid margin to the globe. So there is disruption of the normal ocular surface, which can lead to secondary meibomian gland dysfunction. So a patient with dry eye can have both epiphora and dryness. Paralytic ectropion is another condition that can be present in these patients. Again, because of the orbicularis oculi, there is retraction of, because the poor functioning of the orbicularis oculi, there can be retraction of the upper and the lower eyelids. So these patients can have lag of thalos, which can result in exposure keratopathy. And again, when there is ectropion, basically by definition, the lower eyelid has to be opposed to the globe margin. It has to be in apposition with the globe margin. But what happens in a patient with ectropion is there is a drooping of, because of the laxity of this, this is where the eyelid should have been, but this position is no longer there and the eyelid has drooped, and this is the ectropion. So this ectropion is occurring because of the weakness of the orbicularis oculi muscle, and when this is not in apposition with the globe, the lacrimal pump mechanism gets affected, because as we know, the punctum is situated here, and when the punctum is situated here, this punctum is important for normal tear drainage and it has to be in apposition with the globe. But now the punctum is moved so far away that's not in apposition with the globe, so the lacrimal tear drainage gets affected. And so paralytic ectropion is a problem because of lag of thalos, exposure keratopathy and epiphora. So we use temporary measures or permanent measures to treat this. Temporary measures are aimed at two things. One is we can do what we call botulinum toxin injections, or sometimes we even have to do a tassorrhaphy for these patients. Tassorrhaphy is a procedure which is done to oppose both the lid margins, or we can do a toxin, botulinum toxin. Whereas a permanent procedure that can be done in patients with paralytic ectropion that is not recovering is medial canthoplasty. The upper and lower lids are sutured medial to the punctum, or lateral canthal sling or lateral tarsal strip, where the lateral tarsal plate is refashioned and reattached or levator disinsertion, which is a way of inducing ptosis for these patients, or a permanent tassorrhaphy. Okay, among infections, Ramsay-Hunt syndrome is one of the common causes of facial nerve palsy, and herpes zoster is implicated as a cause.